Yeah, Dr. Hancock, you've already sort of explained a lot of what you do, but just to rehash it, just because some people are still joining, Dr. John Hancock is a dermatologist here in Morgantown. He's a graduate of the WVU School of Medicine, and yeah, as he said, he deals almost exclusively with skin cancer, and it's a very common diagnosis in the United States, but one that is certainly preventable in most cases, as I think Dr. Hancock will explain. And so I'm really excited to discuss this with Dr. Hancock about the different lifestyle habits that we can adopt to reduce our risk of getting skin cancer. So again, thank you all for joining. And yeah, so do we just want to pick up where we left off, or you can sort of summarize what you've said so far?
Yeah, I'll start over if that's okay. I'll be brief.
Okay.
Okay. Well, thank you for inviting me. I'm really happy to talk about this subject because it is definitely a passion of mine, because I just treat skin cancer most exclusively. And if you heard this before, I apologize for the rehashing, but 9,500 people every day are diagnosed with skin cancer in the US. So there's a burden, and almost 200,000 a year diagnosed with melanoma. And I know everybody's aware that that's serious. So my basic advice is to protect your skin from ultraviolet light from the sun. And the three main ways we talk about that is sunscreen or sunblock, broad spectrum, that means UVA and UVB protection, SPF of at least 30, if not 50 and greater, and a water resistant product that won't come off with sweating easily or in the water easily. And then other things include avoiding midday sun from 10 to 2, hanging out in the shade if possible, and certain types of sun protective clothing like hats, sunglasses definitely, and light fitting clothes that can block the sun without having to be reapplied. And I'd also mention, just be careful with water, snow, and sand. If you're skiing on the beach or on the water, all of those can definitely reflect ultraviolet light from down up to get you in places you weren't expecting. And then what I was gonna say briefly was, they call vitamin D the sunshine vitamin. And a lot of us don't like that, because there's better ways to get vitamin D. And we can talk about that as well, than the sun, through supplementation and diet. And then two other things briefly. Tanning beds are evil. Do not get in a tanning bed. I know, except for in cases with things like such as psoriasis or bad atopic dermatitis, we will never suggest a tanning bed unless it's for a medical purpose. It greatly increases your risk of skin cancer, especially in younger populations who tend to use them. And then finally, doing self-exams is very important. Look at your skin like you would at other parts of your body. If you see anything new, anything changing, anything bleeding, it's good to have a skin expert to check out your skin, just to make sure. Chances are it will be nothing, but there's also a chance it could be something like melanoma, which could be life-threatening. And I always tell folks, if you want to know how your skin looked early in your life before the ultraviolet light and other effects from the environment impacted your skin, look at the ulnar side of your forearm. You'll see that your forearm on your medial side, or we should say ulnar side in medicine, is almost perfect. And that's pretty much the way you've been since you were young. But if you look at your dorsal side or your radial side, especially as we get older, you see the effects of sun. And I see that all the time in my elderly patients. So you do see what long-term sun can do to the skin. Now, I have a lot of other things I could say. If you want to just open it up to questions, if there are questions, I'd be happy to answer anything. There's a lot to dig into about those subjects. I think I'd be glad to do that, or I could go on.
Yeah, thank you so much. So I'm Ashley. I am a first-year medical student. I apologize for my voice this morning, but I'll do my best here. But if anybody has any questions about some of the things that Dr. Hancock's talked about so far, or anything that he didn't touch on, please feel free to unmute yourself and ask it, or type it in the chat. But
I'll ask you a question, Ashley. This is Mia. I'm a third-year medical student at WVU. Dr. Hancock, I kind of wanted to know, like, how the difference in sunscreen protection varies depending on what age you are. If, like, younger people should be using different kinds or different strengths of protection when it comes to sunscreen.
That's a great question. I usually advise the same level for all patients, although the younger you are, that's the time when you have the most opportunity to prevent damage. So we know that at least in the decades ago, they tried to estimate that 50% of our sun exposure that we get in our lifetime happens before the age of 21. So if you think about getting 50% of your sun exposure before 21, that means from the time you're very young till the time you're into early adulthood, you should use the highest level if possible. That's not to say somebody in their 70s or 80s should not protect, but there is a decades long kind of latency sometimes in the way this ultraviolet light affects the cells in the skin. So definitely earlier, the higher. And one thing I'll say is, I said earlier, SPF 30 or above, but there's been some studies, including what they call a split face study, where they put SPF 100 on one side of the face and 50 on the other side of the face on the same person. And the 100 was significantly better. So with that said, and the fact that there's been some great studies to show that in the United States, we use between 1/4 and 1/2 of the amount of sunscreen we should use, probably 50 or 70 and up is better, because let's say you get half a 70, you get a 35. Or if you get half 100, you still get a 50. So I go higher numbers, and definitely with younger patients, I think because that's when we get most of our sun, that's what I would suggest.
Awesome, thank you.
can you talk a little bit about what SPF means and what that rating system is about?
Yeah, that's great. So there's a common misconception. SPF is sun protection factor, and it really means the amount of protection you have against the solar energy. So let's put it this way. It's not a time factor. A lot of people think, okay, if I have an SPF 30 on, that means instead of burning in a half an hour, I'll burn 30 times longer in 15 hours. And most of us know there's no way you can be in the sun for 30 hours and not burn. So it's not a time number, it's a relative number. So it has to do with solar energy, which has something to do with time, but it also has something to do with the time of the day, how light your skin is, and the intensity of the sun. So we do know that an SPF 15 has about half the protection as an SPF 30. So it's a relative thing, and it has to do more with the energy that you're blocking as opposed to the time you can be in the sun. The other thing is if you wore an SPF 30 perfectly, so let's say you got your entire skin surface with the amount you were supposed to get, and experts tell us that amount you're supposed to get is about a fluid ounce for the whole body, or a shot glass is an easy way to remember that for the whole body. If you applied that much, an SPF 30 is supposed to block about 98% of ultraviolet light. But since we don't apply it perfectly, and we really can't be expected to, and we sweat some of it off, that's where we think we get about 1/2 to 1/4 of the number on the bottle. So without a doubt, the SPF is about the amount of protection you're getting, but it's not the time. And I think that's a misconception. I know some patients say, well, I have an SPF 50, so I only need to apply it once a day at the beach, right? Because that's 50 times longer. But it may be 50 times more production or more protection than bare skin, but it's not a time thing per se. And one more thing, all this stuff is done in the lab. So everybody has a car here, and you know your miles per gallon says 24 on the window, and you drive through West Virginia and you get 18 or you get 16 because you're driving up hills and in you step on the gas really hard. Same thing with sun protection factor or SPF. We just don't get what's on the bottle, even if we use it the best we know how, because of sweating and because of application.
We have another question in the chat about perhaps the positive aspect of sun exposure. Taylor was asking about vitamin D and ways to get adequate amounts of vitamin D.
Okay, well, that is a good question. Without a doubt, vitamin D3 especially is produced in the skin when ultraviolet light hits your skin. I'll say a couple things. Number one, there's no good data to show that if you wear sunscreen and you're in the sun a little bit, you block production of vitamin D, okay? So you still get vitamin D production when you're in the sun if you're wearing sunscreen. It may be lessened, but you still get it. It doesn't take a ton of time in the sun to get vitamin D during the day. And then supplementation has been shown to be pretty beneficial. The recommended daily allowance or the recommended amount varies by age, but it's about 800 international units for an adult. And I think getting it through, milk is fortified, all kinds of dairy products are fortified, and there's lots of other ways to get vitamin D other than from the sun. And I think most governing bodies, including the kind of governmental bodies and even a lot of academicians, say that they suggest you don't try to get your vitamin D only from the sun, just because the risk of skin cancer is high enough. And incidentally, one other thing I wanted to say, because when I was in training, there was research from Boston, I think it was from Boston University or Boston College, perhaps. There was a fellow up there that was really digging into the fact that vitamin D has, if you're insufficient, has a lot of negative consequences. And some of that data is being reevaluated. Clearly, if you're very deficient, it's bone health that's the issue. We know about the disease rickets, which we don't see anymore, but clearly vitamin D has a lot of benefit on bone, especially for patients at risk for osteoporosis, so older patients. But besides the bone health, the data on health for everything else is not quite as strong as they once thought. So I suggest supplement, eat healthy, and try to limit your sun exposure.
Dr. Hancock, I just wanted to ask a follow-up question to that. What foods can you eat that are really rich in vitamin D?
Well, for one, like I said, dairy products will help. The leafy green vegetables, so milk and cheese and meat would be beneficial. But if you look at the containers on a lot of things, even orange juice these days are often fortified with vitamin D. So they saw there was an issue decades ago, and they started putting vitamin D in lots of other foods. And then it's just easy to get a supplement. And I tell folks, ask your primary care physician for a serology if you have any concerns. They're often doing that these days. And if you're normal, fine. If you're not, talk to them about excellent ways to just supplement on a daily basis.
Thank you. We have another question in the chat here. Linda wanted to know about sun damage that you might get through glass, for example, when you're driving.
Okay, great. Well, glass typically blocks ultraviolet B. So ultraviolet B is, since you guys are often mostly medical students, is 290 to 320 nanometers. So 290 to 320 is ultraviolet B. So it's a shorter wavelength than ultraviolet A, which we'll talk about. But the glass in your car should block UVB. Now, that's typically known as the burning rays. It's also related to skin cancer most heavily, and aging and things of that nature. So in your car, you tend to get UVB block, not always UVA and other glass through buildings and whatnot, unless they have put a agent or a chemical on it to block UVA. So if you don't know, assume you're only getting some UVB protection, and therefore if you're on a long car ride, or in a glass building of some sort, I would suggest some protection, at least to get ultraviolet A protection as well.
Yeah. I have another question. What role does the reapplication of sunscreen play in sun protection? So when you put it on, when do you need to reapply, and or are you set to go?
Okay, that's a great question. And that's actually one of the things that is most often neglected and why we don't get the number we should. So the bottle is your guide. So if you pick up a bottle and flip it over, it will tell you exactly what the manufacturer suggests. But most of us in our world say at least every 2 hours. And the reapplication is important, partly because there's some breakdown molecularly. There's also sweating and other things that would cause it to go away. So the easy way to remember it is at least every 2 hours, unless you're in extreme conditions where you're sweating profusely, or you're swimming, or you're going to be wet often. And therefore, you want to go to your bottle again, but it's at least every hour. And in some cases, believe it or not, even every 45 minutes. And a follow-up on that is when you read on your bottle that it says water resistant. In the lab, water resistant on the bottle of sunscreen means that you're protected for 4 20-minute immersions in water. I know that sounds very technical, but it's basically 80 minutes in water you're protected. Or I'm sorry, 40 minutes for the water resistant and 80 minutes for very water resistant. So even if you have a sport sunscreen that says it's very water resistant, they're only promising you 40 minutes of being in the water before it starts to lose its effect. And so an application every 2 hours if you're dry, perhaps, and then every hour at least if you're not going to be dry.
Okay, so we have a related question about applying sunscreen. Is the type of sunscreen you should use, is it better to use spray or a cream that you apply?
Okay, that's a great question as well. I'll just tell you what I've done, and then I'll tell you what maybe some of the science shows. Most people suggest a cream or lotion on the face or the neck and the ears and the forearms and the hands, the easy places to get at least, especially the face. And don't forget the top of your head and the top of your ears and that type of thing. I use the sprays for the body because of the speed of application. And in that case, I would get the highest number possible. And that gets us into the ingredients. And I'll just tell you that most of the folks that do what we do suggest either zinc oxide or titanium dioxide products. Those are what we call physical blocking agents for the face or the highest exposure areas. And they're harder to get on. So that's why maybe we don't suggest that for the entire body, because that's a lot to put on. And if you've used that stuff, it can leave a white sheen on you. But the physical blocking agents of zinc or titanium for the face in the highest areas, and then the sprays or lotions with any of the agents, as long as the SPF is high enough for the rest of your body, following all the instructions that they tell you.
Okay.
Actually, can I ask a follow-up question to that one too?
Go for it.
Okay, so I was kind of wondering, how does your recommendation on sunscreen change, if at all, depending on different skin tones?
Okay, so that's a great question. So I would tend to suggest everyone. However, for people of color, and the skin type is graded 1 to 6, so that your fairest skinned individual would be a freckled patient with green or blue eyes, might be your descent from, let's say, Ireland or Scotland. That would be a Fitzpatrick type 1 at most risk. So you would want to ramp that up and tell them, those people will tell you I'll burn in 5 or 10 minutes in the sun unprotected. So they may want to, double their time for reapplication and not even take a chance at being out in the sun. When you get into a Fitzpatrick 6, which would be a darker skinned individual, very dark, who would take a long time to burn. And the data for people of color, especially people of darker skin types, in terms of needing to protect for skin cancer is weak. So what I'll say about that is, let's say African-American patients, sunscreen protecting against skin cancer is not as big of a deal because the risk of skin cancer related to ultraviolet light is much lower. However, we know that people of color get melanoma, let's say on the palms and the soles of the hands and the feet, under the nails, and in places that are not sun related. So of course, there needs to be awareness there. But in terms of the sun protection, if you're darker, it will help you in terms of things like wrinkles and freckles and other things that have to do with aging. It's not quite as protective against skin cancer because they just don't get skin cancer. People of color do not get skin cancer at the same rate. And that's a broad answer, because when you say somebody of color, it could be somebody from a Fitzpatrick 2 or 3 who's, let's say, has Mediterranean type skin from Italy or Spain, all the way to somebody who is darker, let's say from the nation of Ghana or the nation of Uganda, who would have a Fitzpatrick type 5 or 6. So there's not a lot of scientific data there, except you can tell when you see somebody who's freckled and has red hair and light eyes, you need to be extraordinarily careful. And so I would take the recommendations and even make them more stringent.
That's very helpful. Thank you.
Yeah, thank you so much. We have another question in the chat here regarding skin cancer. Is there a higher risk of skin cancer if you've had it before again in just one place? And or if you have one type of skin cancer, are you more likely to get a melanoma later on?
Okay, great questions. I'll talk about melanoma briefly. After the diagnosis of melanoma the first time, most of the data says your risk of a second primary melanoma. So this is not a recurrence of the one that was just treated per se, but another one developing somewhere else is about 10%. So you can say 10% as the glass is half empty, or you could tell them you have a 90% chance of never getting this again. That's melanoma. With non-melanoma skin cancer like basal cell carcinoma or squamous cell carcinoma, there's a lot of factors there, but the risk is much higher, probably 25 to 50% lifetime of getting a second primary carcinoma. And then getting back to the recurrence of the ones that were already treated, a lot of that depends on the stage of melanoma. And there's great data on those Kaplan-Meier survival curves and things of that nature, or just there's even a calculator you can put in online about what's your risk of this melanoma coming back, given all the data. And then the other types, the carcinomas, they are unlikely to come back if treated appropriately, but the risk is higher. So all that to say, about 10% for a second melanoma lifetime, and much higher than that, maybe 25 to 50% for non-melanoma skin cancer. And a lot of that depends on your genes, your sun exposure, and whether you have certain conditions like you're a transplant patient on immunosuppressive medications, and those people have a much higher risk of skin cancer all total.
Thank you. We also have a question, Dr. Neild. What is the biology behind your skin being more at risk for skin cancer?
Okay, so great question again. As we talked about skin types, so melanin is the portion of your skin that sits on top of what's called the basal layer of the epidermis. So people who are of darker skin types have larger kind of conglomerations of melanin, so they have more shade, essentially, or more protection. So the melanin protects you from certain types of damage from the sun. So that's the protection part of it. The part about biology in terms of getting skin cancer, first of all, has to do with genetics, like everything else we have. So if you have a family history, it increases your risk. Your sun exposure is very important, because ultraviolet light does cause breaks in DNA. And if it causes breaks in DNA and they're not properly repaired, and of course that gets passed on one of your keratinocytes in your epidermis, then you have 2 cancer cells, then 4, then 8, and then the whole thing kind of blows up. So part of it is the genetics towards that tendency. Secondly, it's the amount of melanin you have in your skin and the protection you give it. And the more onslaught of ultraviolet light you have, the more breaks you get in the DNA and the more damage. And it's interesting to note that a squamous cell carcinoma of the skin, when it's genetically tested, often has more genetic errors than almost every other malignancy in the body. And the reason I say that is that tells you that it often takes multiple hits to the genome before certain things convert. And that's why sun protection is important, because oftentimes my patients are in their 50s and 60s and 70s, and they've had a lot of sun exposure 20 or 30 years ago, but maybe not so much in the last few decades. But I tell them it's the accumulation, it's all those errors in the genome, it's all the assault of sun protection that add up. And so there are all kinds of genetic defects, like genetic defects in P53, the signaling cascade, things in what they call the MAP kinase pathway, which you guys I'm sure are learning about, and a whole host of other signals about cell regulation and cell division. So it's pretty complex, but I think if you look at genes and you look at your skin type and you look at the amount of damage you have, then there's a picture for each person. And unfortunately today, we don't have a great kind of number to put on folks in terms of what your risk is. I wish we could, maybe someday we'll have a great grading scale genetically and we can tell people you're a 10 risk and you need to be super careful, or you're a 40, you still need to be careful, but not as hard as the person in the 10 risk.
I wanted to ask a follow-up question on that regarding risk factors. Do you see an increase in incidence of skin cancer among people who are metabolically unhealthy, who have insulin resistance or hypertension or heart disease?
Well, I don't think so. No, I'm not aware of any data about that. I know that immunosuppression is critical, and the immunosuppression we typically see is in a couple ways. Number one would be obviously patients on drugs like azathioprine, tacrolimus, and things like of that nature for solid organ transplants. So we know that immunosuppression plays a role. So that would also go forward for patients that have lupus and other conditions of that nature. But in terms of the metabolic syndromes, people that are overweight with hypertension and type 2 diabetes, maybe not, except for some of those factors that are kind of personal choices about lifestyle may play into the fact that they're not protecting themselves from other forms of harm. So maybe sun protection is not on their radar screen as well. So I think that might be a bigger factor than anything else. It's just the idea that if you're careful with what you eat, that you don't smoke, and other risk factors, you may be more careful with sun protection. But yeah, we know some things like smoking has some risk in terms of that regard, and other factors that are unhealthy from an environmental standpoint, maybe being exposed to certain types of hydrocarbon at a workplace, or arsenic, which isn't done very much. But yeah, I'm not aware of a direct link between those factors, but without a doubt, if you're a healthy person and trying to protect yourself, most of those people would put themselves in that category as well.
Okay, thank you.
All right, we have a couple of related questions about how to do a skin check at home and what to look for, and then when to see a doctor whenever you notice something abnormal.
Okay. Well, the skin check at home can be challenging for parts of your body you can't see easily. So, there's a suggestion, obviously, to use mirrors to try to see your back in places that aren't obvious. And people in adolescence and into early adulthood are allowed to have new moles develop. But as you become over 21, it becomes much less common that you would get new moles. So I will tell people, if there's anything new that grew on your skin as an adult, I would be really careful with allowing it to go. And you guys have heard this probably before, but some of the main factors we talk about in terms of at least brown spots or moles would be asymmetry. Are the two sides equal if you cut them in half? The border, is the border regular and nice and round, or is it irregular and jagged? The color, do you have one color or 2, 3, 4, and 5 colors? The diameter, usually they talk about greater than the size of a pencil eraser, or 5 or 6 millimeters or greater has a slightly higher risk. And then the E in the ABCDE mnemonic stands for one of two things. The most common thing it stands for is evolution. So if you see something on your arm that used to be 3 millimeters and light brown, and all of a sudden it looks like an ink spot and it's jagged and 6 millimeters, then that needs to be evaluated. Now, all that is talking about things in the melanoma category, those ABCDE criteria. Younger folks typically do not experience basal and squamous cell carcinoma, but in the adult population and in the older adult population, anything that's new, especially anything that's bleeding and something that may have some symptoms to it, like itching, pain, tingling, burning, it's just safer to have a dermatologist check you out. And a lot of those visits are going to be for benign growth, but at least you don't miss something in that regard.
Yeah. We had a question a while back about the sort of anti-aging side of, or the aging side of sun exposure. And somebody asked, do anti-aging miracle creams, do they work? What are your thoughts on that?
Well, first of all, we do know that sunscreen works, and and sunblock and sun protection. There was a great series of photographs that were done about 30 years ago where a plastic surgeon in New York took pictures of the face of identical twins. So the identical twins, of course, had the same genetics. One was very careful with the sun and one was not. And he took the pictures before he did any type of cosmetic work on these women. And it looks almost 10 or 15 years difference between the two sisters in purely protecting themselves from the sun. So we know sunblock, sunscreen, sun protection is your best option. Now, other things like moisturizing your skin, obviously, if you know you have your automobile, your seats, if they're leather, they crack over time and you have to keep them supple so they don't crack as much. But moisturizing your skin is very healthy for the skin, helps with your protective barrier and that type of thing. Avoiding smoking, of course, for all other reasons is a problem, but it's definitely a downside in terms of the cosmetic appearance of your face. Now, in terms of the other stuff, there are some medical treatments, which I won't get into. But in terms of the quote unquote magic creams, most of the topicals that have been out there over the years have had moisturizers and a whole bunch of things that were supposed to be added to the skin to make it appear better. You know, with everything else, you get what you pay for. And sometimes, you know, if you pay for a cream, you can't expect to be 20 years younger. So it's all in terms of starting out right in your teens and 20s. And if you would see these pictures of these identical twins, one with protection and one not, you'll see that the ultraviolet light has a huge impact. It's one agent that's often put into anti-aging serums, creams, and lotions is one of the retinoids, or a vitamin A derivative. And they're of varying degrees of benefit because the prescription ones are much better, but the ones that are not prescription, of course, are not going to be quite as impactful. That may have some benefit, although that's not kind of my field of expertise. But I will tell you that sunscreen and moisturizing are the two best things you could probably do for your skin in the long term. And you could talk to your dermatologist about all the other stuff if you want to try something in addition to those two.
Okay, thank you. We had another question what additional practices would you recommend for somebody who uses acne treatments like benzoyl peroxide, and with that increased sun sensitivity that comes with that, or is regular moisturizer with SPF a good standard option?
So, and that's a good question. And also, if you're on acne treatments, doxycycline, the antibiotic, does increase your risk of ultraviolet light causing some damage. And retinoids, like if you've been on Retin-A or Differin or drugs that are the prescription saying retinoids, the first month you're on them, they can thin the epidermis and therefore make you a little more prone to having trouble. Benzoyl peroxide does do something to the epidermal barrier in the short term. But I'd probably just reiterate what I was saying before is when you're done with your acne regimen, you want to put a sun block over top of it. And for the first month, if you're on retinoids, topical retinoids like Retin-A, be very careful. And if you're on doxycycline antibiotic, be extraordinarily careful the whole time you're on it because it's easier to burn. In terms of the moisturizers with sunscreen, there again, look at what's in it. Look at the number it gives you and follow the instructions. They are typically a little less effective. However, whatever you'll use is the best thing. So if you won't use sunscreen, unless you're putting it on with your regular routine with moisturizer, then by all means, use a double kind of benefit product like that. And so a lot of women who wear facial makeup, they make SPF all the way to 100 in terms of foundation and things of that nature. And for those folks, it's a one-shot deal. You don't have to apply 2 different agents. So, but yeah, no question, some of the acne regimens make you more sensitive. So play, the same rules as everybody else, but maybe more intensely, especially while you're on treatment.
Okay, thank you. We have another question regarding selecting an appropriate sunscreen. So we asked if you have any brand name recommendations for things with zinc, titanium, and water resistance all in a package.
Okay. Well, I try to avoid brand names just because I don't want to sway anybody towards one company or another. But with that said, I'll say a few things. Whatever you feel like feels good on your skin, use that. And so there are some products that aren't greasy and aren't heavy. And a lot of people say, I like those better than the ones that feel like I have grease or I have peanut butter on my face or something like that. So whatever you'll use is the best one. Look at the ingredients, like we said before, zinc and titanium, best for heavy exposure. And then maybe consider a spray for the rest of your body. Consumer Reports, the company looks at everything from washing machines to cars. They will look at sunscreens occasionally and give you a biased or unbiased, I should say, unbiased review. And in the past, they've found things as cheap as Walmart's generic brand to be beneficial. And then stuff as expensive as some of the stuff from La Roche-Posay, the French company, which are very expensive. So I would say if you're going to be somebody who swims, somebody who sweats a lot, get a sport sunscreen and get the ingredients that we talked about, the zinc and titanium. Make sure you get it very water resistant because most people run into trouble when it sweats off or they don't reapply. And if you don't like the way it feels or it's too burdensome to put on, people aren't going to wear it. And so I'm going to try to avoid brand name recommendations. I would just shoot for those rules because I think if an unbiased organization looked at it and found everything from generic and Target brands all the way to Neutrogena and Aveeno as being pretty good, you can't always pay more and get the best thing, but sometimes you can. So look for broad spectrum, look for SPF 30, 50 or higher, look for zinc and titanium, and look for very water resistant.
Thank you. Related to that, do you have any recommendations for kind of increasing the sunscreen compliance for yourself or for those around you?
So that's a great question, and not to sound like a broken record, but try several or ask your dermatologist for samples and see what you like, because therefore, if you like it, you use it. That's one. And the one thing that I've found and that has been helpful is that idea of the heavy stuff on your face and ears and neck and the spray on your body, because it's fast and most people can tolerate it. The only problems with the sprays are a few-fold. Number one, you don't want to spray your face because you can cause, irritation to your conjunctiva, and you don't want to inhale that if you can possibly avoid. So spray away from your face. If you're spraying, one of the concerns people have with sprays, you don't know necessarily if you covered everything. So if you spray, you want to be very kind of generous and maybe spray twice. You also want to make sure that everything dries. So we usually tell people 15 or 20 minutes before you're going to be in the sun, apply, so you have time for that to settle into the portion of the epidermis you want it to be in, and so that it doesn't immediately wash off or sweat off or go off in the water. And then back to your question about compliance, if you find that there is a product you'll use and it's a moisturizer plus sunscreen, that can help with compliance because it kills two birds with one stone. And in the same way, that's why I suggest makeup for women, just because if they're going to put that on already, make sure it has it on there. But compliance is all about, I think, people's tolerability or what they like. And it may be easier for certain people than others. But if you can get in a habit, habits are hard to break once it becomes part of your routine.
Yeah, we have another question in the chat here. So we have a broad question about the treatments for skin cancer. Are there any newer emerging therapies for different types of skin cancer? And if not, what is the sort of current standard of care?
Okay, well, that's a great question. It depends on the type of cancer. So with the most common types of skin cancer, basal cell carcinoma and squamous cell carcinoma, there are excellent guidelines that the National Comprehensive Cancer Network puts together that we're supposed to be guided by. And honestly, it depends on how deep the cancer is, where the cancer is, some other pathological factors. And so what I do all day is surgery. And I typically do surgery on the face or cosmetically sensitive areas without a lot of skin. And in Mohs micrographic surgery, we remove the skin cancer and we do the pathological examination there so that we're sure that it's gone, and then we repair the wound that's made. That's not the only way to treat skin cancer. You can have it surgically excised and repaired and then wait for pathology. That's another obviously surgical option. There's some other techniques surgically used where you just scrape off the skin and then cauterize the area you scraped off for low risk cancers. Those are more of the skin cancers that aren't quite as deadly. If you have a higher stage squamous cell cancer, you will be at the cancer center with a head and neck oncology surgeon. You will likely have to have radiation. You may have to have chemotherapy. And melanoma is really where this is all blown up in terms of new treatments for metastatic disease, either that's in the lymph nodes, stage 3, or widely metastatic, or stage 4. And most of those treatments revolve around what's called checkpoint inhibitors, where there's a certain cell signaling pathway that you can block to stop the proliferation of melanoma, say, without making the patient so sick. And they're much better than they ever were. So the last 20 years has been kind of exciting for melanoma care, because some people who in the past would not make it are actually surviving based on some of these checkpoint inhibitors that are also much more tolerable. And then, so that's probably the latest thing out there. There are some topical preparations for very superficial cancers of the basal cell and squamous cell variety. And then finally, one we didn't talk about that's becoming more common is called Merkel cell carcinoma. And that is what used to be called a neuroendocrine carcinoma, which is an interesting cell, but it also has an ultraviolet component to it as well. And in most of those cases, they have what's called the Merkel cell polyoma virus is positive. So it's maybe viral mediated and ultraviolet mediated. And that is the deadliest of all the skin cancers we run into, with a third of people dying at 5 years, which is 3 times as deadly as melanoma. So, but there again, I bring that up because Merkel cell carcinoma does have ultraviolet light exposure as one of its factors. And the treatment of it is surgery, radiation, and these new checkpoint inhibitors that we just talked about that have revolutionized melanoma care.
Okay, thank you so much. This might be our last question, but going back to prevention, do you have any advice generally or specific resources on teaching ways to teach young children about the importance of skin cancer or skin protection?
So for kids, a lot of our data comes from the American Academy of Dermatology's website, aad.org. That's aad.org. And they have some resources for kids, although I haven't had to look at that lately. Most of what I obviously deal with is in adults. And my also advice with anything medical is I will, if I'm looking for something good, I'll either go to Mayo Clinic or Cleveland Clinic or Memorial Sloan Kettering or those major cancer centers in terms of to see if they have resources. But I would start at the American Academy of Dermatology's website. I think that would be, they would have some stuff for kids. And then again, of course, educating parents to start kids on a regimen so that they know before they go out in the sun, whether it's to the beach or out to play ball or just out to be in the yard. If they get used to putting on sunscreen, it will become part of their routine so that they think it's normal to wear sunscreen, as opposed to trying to start something when they're in their 20s, as opposed to something they're used to since they were the age of 6.
Thank you. And Dr. Neal also added in the chat that the American Academy of Pediatrics website may also have some good resources.
Oh, right. Excellent. Yeah, I'm sure they do, without a doubt.
So Taylor just posted the link to a survey in the chat that you can take that would really help us out to hear about how your experience was at the walk today, and you can input any topics you'd like to hear on future walks. And Dr. Hancock, if you'd like to sort of give us a sort of a summarizing spiel about what we talked about today, some key takeaways for us, that would be great.
Love to. One other thing I wanted to mention before I leave that's more of a later discovery in the last 10 years is the use of nicotinamide, which is a B3 vitamin. And look that up, nicotinamide. There was a great paper, a phase 3 study in the New England Journal of Medicine out of Australia that showed taking nicotinamide, a B vitamin, twice a day for a year reduced the risk of skin cancer in highly at-risk skin cancer patients who've already had cancer by about 1/4, and also precancerous lesions by 1/3. So nicotinamide, I'll throw that out there. We don't know use in patients who are young, who've never had skin cancer, but we know the high-risk patients, and there's almost no risk to that. So that's probably one of the latest things. But I'll just say again, protect yourself from the sun. A sunburn is like cooking at 250 in the oven. A burn is like cooking on broil at 500 in the oven. A tan is damaging, so don't get suntan. If you have to have a darker skin color, use it in a bottle. Get it from a bottle. Protect yourself from the sun, because not only skin cancer, but the appearance of your skin will be much worse in the future. And if you get into good habits now, and even if you're my age or older, you can make a big impact on your future. So enjoy yourself, just protect yourself from the sun. You don't have to avoid the outside, just don't get burned or tanned.
All right, Dr. Hancock, thank you again for joining us today, discussing this very important topic. Again, Ashley already mentioned it, but if our listeners today could please take the survey just to let us know if there's anything that we did particularly well today, or if there's anything that you think we could improve on, or if you have any ideas for topics that we could cover for future walks. So please take that survey. We would really appreciate it. We would also appreciate it if you could type in your name and where you're walking from in the chat. That's something we always like to see. And of course, WVU Walk with the Future Doc continues to reach outside of Morgantown, West Virginia. And we have listeners from all over the country and sometimes even all over the world joining into our walks. So yeah, of course, we'll have our next walk in 2 weeks, again, Saturday, 9 a.m. And yeah, if you learned something today, again, certainly check us out on YouTube and Facebook, and certainly recommend us to anyone that you think would benefit from the information we talked about today, or perhaps in past or future walks. So yeah, I think again, that we had a good walk today. And Dr. Hancock, thank you so much for your time with us.
Well, thanks for having me. I had fun.
Thank you.
All right. Bye-bye.
Yes, thank you so much. Thanks everyone for walking today. We hope you have a good Saturday and enjoy the sunny weather if it's nice outside where you are, but remember your sunscreen. That's what we learned today.